Statins are probably the best public health intervention for reducing serious cardiac diseases, strokes, and death. However, an individual person may never feel or realise the benefits. So, are they worth the risk of side effects for you and your loved ones? Statins do reduce the risk of heart attacks and stroke by a quarter, but how does that compare to the risk of side effects on your muscles and liver? What is this Qrisk that your doctor uses to say that you need a statin? And what are the NHS targets that they are chasing? I will discuss all of this and more, giving you the facts to make an informed decision on your health. There'll be timestamps in the description box below, as well as references. But before I start on the content, here are my disclaimers. I'm Eloise, I'm a UK pharmacist of 20 years, and I'm enthusiastic about clear, accurate information on medicines and supplements that everyone can understand. The information I provide is for educational information only and is my own opinion. However, I do base it on the most up-to-date evidence. Always contact your own healthcare professional for individual advice on your own personal situation once you have listened to this video. Also, if you could like, subscribe and share this content with others, that would be great to get the message out there so that more people can make informed decisions about their healthcare. So, what are statins? Atorvastatin is the number one most prescribed medicine on prescription in England, with 61 million prescriptions a year at a cost of over £100 million. But how did we get to this point? Research back in the 1970s found that people with higher cholesterol were more likely to have heart attacks and die from cardiac disease, which at the time was the number one cause of death in developed countries. This started a competition of pharmaceutical companies in producing drugs that could lower cholesterol, including the statins. The statins proved to be excellent in lowering cholesterol levels, but did that mean they actually saved lives? So in the 1990s, there was a large double-blind placebo-controlled trial, which is the gold standard, called the Heart Protection Study, and it followed over 20,000 people with existing coronary heart disease or diabetes over a period of 5 years and proved that simvastatin 40 milligrams cut the risk of heart attack, stroke, and death from heart disease by 25%. And that was regardless of the patient's cholesterol levels at the start of the trial and at the end of the trial. Just taking simvastatin was proof enough that it lowered the risk of heart disease and death. We then moved into the 2000s. At that time, I had just finished being a basic grade, doing 3 years of rotation at a hospital pharmacy, and I had just moved into primary care, where I was writing guidelines for GP practices and helping them make the most out of their budgets. And at this point, the Heart Protection Study had just been released. There was more and more evidence about statins. All the companies were pushing that they had the best statin. Theirs was more potent. Theirs was going to provide the biggest reduction. But also at that time, simvastatin came off patent and suddenly dropped in price. And there was all the generic companies fighting for having the cheapest version and trying to get hold of the majority of the market for simvastatin. So this raised all the questions of, should we stick with atorvastatin that seemed to be more potent, or would it be better to treat more patients with simvastatin and be able to, although it might not reduce the risk quite as much, would be able to treat so many more patients with the same amount of money that actually overall for public health we would actually be saving more lives overall. And this was part of my training in learning how to really develop critical appraisal skills and find those balances. And so, yes, back in the early 2000s, we did a lot of switching people onto the generic versions of the simvastatin and getting as many people as we could who have had cardiac disease onto a statin. How come 15 years later, atorvastatin now has this top spot? Obviously, atorvastatin came off patent, as did the other statins and the other agents that could lower cholesterol, such as the fibrates and ezetimibe and the omega fatty acids. So lots of money went into the studies to compare all of these agents. Obviously, all the pharmaceutical companies wanted to show that their agent lowered cholesterol the most, but also would be able to prove that they also lowered the risk of heart attacks, the risk of strokes, and most importantly, the risk of deaths. They all managed to show that these reductions, especially with the statins, not so much with the fibrates and the ezetimibe, even though they did reduce cholesterol, the statins really showed out at showing that they lowered the cholesterol and lowered the risk of the cardiovascular disease, the strokes, and the deaths. They all then compared their potencies, and yes, there was differences in potencies, but it was realised that even if the potency may be different, if you had the same amount of cholesterol lowering between the statins, you would then get the same reduction in cardiovascular disease and death. So they realised that although simvastatin 40 was the drug of choice, they tried to get people up to simvastatin 80, which would lower cholesterol even further, and it did also show a reduction in mortality, but not as many people were able to tolerate that. But then, however, giving them atorvastatin 40, which was the same potency and lowering of cholesterol, people were able to tolerate the side effects better. There was then trials to see whether people could use rosuvastatin, which seemed even more potent. You would only need doses of either 10 or 20 milligrams to get them same lowering effects. But it turned out that people got more side effects from the muscle cramps and such like from rosuvastatin, that it never really got the same momentum and acceptance by GPs for using. So with all this trial data, it became obvious that the best and most efficient way of lowering cholesterol, reducing cardiovascular disease, stroke, and death was using atorvastatin 40 milligram and even 80 milligram as the gold standard. You have probably come to this video because you've either taken a statin yourself or you've been asked to take a statin by either your nurse or GP, maybe because you've got high cholesterol, you've had a heart attack, you've got risk factors for heart attacks such as high blood pressure or diabetes, and you're trying to get your head around whether taking this tablet every day for the rest of your life is actually going to make any difference to you. Is it going to stop you having a heart attack or stop you having a second heart attack? Or is it just going to cause you side effects and cause you problems? To work this out, you actually need to find out what your individual risk of having a heart attack over the next few years is. If your risk of having a heart attack over the next few years is very low, there's probably no need to actually be taking a tablet that may cause side effects. However, if your heart attack risk over the next few years is very high, you'll be wanting to do everything you can to lower your risk. And although some risks we can alter with our lifestyle, the majority of risks we can alter, such as our age, our family history, and most of our genetics. So we may need to rely on other external resources to try and lower that risk of having a heart attack, because it's not just the reduction in your lifespan of having a heart attack and dying. After having a heart attack, it can severely impact your quality of life and what you're able to do and what you're able to enjoy. So that's why we need to work out what is your risk. And we do know that if you've had a heart attack, that can easily double or quadruple your risk. And so they usually say if you've had a heart attack, you're in that high enough risk factor that even if you're doing everything else with your lifestyle to really help, a statin will be of benefit. But if you haven't had a heart attack, quite often a GP will go through with you a Qrisk assessment to try and calculate what your risk of having a heart attack over the next 10 years is. So, and it'll usually come out with a percentage, such as a 10% risk is in the next 10 years, there's a 10% chance that you would have a heart attack. So out of 100 people, exactly the same as you, exactly the same genetics, lifestyle, current medical condition, If all of you just carried on your life for the next 10 years, 90 would be fine, but 10 would be having a heart attack. And obviously, a certain percentage of those would also be dying due to the heart attack. You could then end up with Qrisks of up to like 50, 60%, especially if you've got really high risks, genetic risk factors, you've had a heart attack, such as 50%. So you've got a 1 in 2 chance over the next 10 years of having a heart attack. I'm going to go through a Qrisk assessment that is available online for everybody to see, to show you which sort of risk factors are on this, some that you can't modify and some that you can modify. And then after then, I will go through how much a statin can impact your Qrisk going forward. The link for this website is in the description box below so that you can go and fill it in with your own statistics. So you can fill it in with your age, sex, and then go down. And obviously there's some things that you can alter within your lifestyle, such as whether you are non-smoking, an ex-smoker. And then you can fill in about your family history of heart attacks, different things that you've may or may not have that may impact on your risk of having heart disease. So things like you may think it's unrelated, such as a treatment of erectile dysfunction, and that's because it's known that that is due to blood flow, and blood flow is also important for your heart and your risk of heart disease. And then going down, if you do have the statistics, you can add them in. If you do know what your cholesterol to HDL ratio is, HDL is the better of the cholesterols, whereas the LDL, the low density lipoproteins, and the very low density lipoproteins are the more dangerous ones. So putting in the ratio of that helps provide an indication on your risk factors, also your blood pressure, and then adding in your height and your weight. So I can put them in, and then once you've done all of this, then you can calculate your risk, and it will give you a nice diagram giving you a visual representation of your risk. So there's 100 faces on here. The majority of the yellow smiley faces are those people that will carry on for the next 10 years, not having anything go wrong with their heart or a stroke or anything related to that. That doesn't mean that they won't get other conditions or, come down with anything else, but it's due to the risk of the heart attack or stroke. However, the blue unhappy faces show the amount of people that will have a heart attack or a stroke or even die from the heart attack or stroke. And with the statistics that was put in there, it was a risk over the next 10 years of 12.3%. So if there was 100 people with exactly the same statistics, exactly the same risk factors, 12 of them would end up hospitalized and having issues, and but the majority of them, 87.7% will be able to have nothing go wrong, except for you don't know whether you are going to be a yellow or a blue face. So we can go on here, we can alter some of these. So if you've got a first degree relative that's had a heart attack, you've been on blood pressure treatment, you've had to take steroids, and then your weight's not being able to be kept as under control, you can recalculate your risk, and as you can see, the risk has gone, and now it's nearly at 25%. It's nearly at a quarter of people with these risk factors having a heart attack. So a 1 in 4 chance of having a heart attack or a stroke, which you would probably say is not good odds over the next 10 years. And you would be wanting to try and see if there was anything that you could modify. So look down here, there's not many of these that could be modified by people. If you're male, your age, you can't alter that. Smoking status, already a non-smoker, can't alter that, can't alter anything about the medical history there. And even the weight here is not a massive weight. So again, it's not something that can be modified, just generally being at that risk. So what can we do to lower the risk factors? And now I'll go on to saying when you can decide on how to take a statin for yourself. What is the benefit for you to take a statin? We already know that for public health, it would reduce the amount of heart attacks and strokes and deaths by a third by ensuring people that are at high risk are on a statin. But you've now calculated your risk. You may be low, medium, or high risk. You may have some factors that you can alter yourself. So, should you start a statin? And for this section, I am going to use some of the decision aids that are on the NICE guidance document. It's available and linked below. So it's a patient decision aid made by the National Institute for Clinical Excellence, which the NHS use for providing all the guidelines. And it goes through sort of what all the different things about heart attacks and strokes, what you can do to reduce your risk, and then goes on to show how your risk of heart disease then relates to how effective a statin can be. So take the risk of you being very low risk of having heart disease and a stroke over the next 10 years. If your risk of heart disease or a stroke is only at 8% over the next 10 years, so 100 people exactly like you over the next 10 years, 92% of the people will not have anything to do with a heart attack or stroke. But there will still be potentially 8 people that will have a heart attack or a stroke. That's just the odds. You've no idea to be able to predict which ones of those people with those attributes are going to be at risk of this. It's like buying a lottery ticket. You don't know what the number's going to be until they are pulled out. However, we do know that if you treated all 100 of those patients, including the 92 that nothing would happen to, out of those 8 that would have had something happened, you're going to prevent 3 of them having a heart attack or a stroke. But 5 will still go on to have a heart attack or a stroke, because even though the statin has reduced their risk, might have made it slightly more mild, they still have gone on to have a heart attack or a stroke, and there was nothing the statin could have done to prevent that. So where you fall in that, you've no idea. And we only know that on a public health setting that this would happen. When it comes to looking at the costings of giving everybody a statins, the risk of side effects for this, it has been determined that it probably isn't cost effective, and it's probably not worth the risk of side effects to treat people that are only at a very low risk with a statin over that 10-year period. So you may also decide that if you are at a low risk like 8%, you probably don't need to. But what you might want to do is just look at your lifestyle to try and keep yourself at that low risk over the next coming decades of your life, so that you don't then creep up into the higher risks. But let's move on. Things have moved on. 10 years later, you've got multiple other conditions going on. Different things have happened in your life, and suddenly you find that you go for your risk assessment, and now your risk assessment's at 40%. And here you are, you're at a point, you've tried your best with all the lifestyle, but here's your risk at 40%. So 100 people, exactly the same as you. We know that 60 of those people will actually be okay over the next 10 years and not have a heart attack or stroke. Not saying that they won't have anything else happen to them, and they will be okay. But there's a good 40% chance that something will happen. However, if we give all 100 of those people statins, we know on the whole we will be able to prevent 15 of those from having heart disease and a stroke, and potentially prevent them from dying. And that, on a public health way of treating 100 people, to know that we are stopping heart attacks and strokes in 15 of those, that is very worthwhile. And you might think that is very worthwhile for you as well. However, there is still the risk, still a 1 in 4 chance that you'll be one of those unlucky people that, even though statins reduced your risk a bit, you're still going to go on and have a heart attack or a stroke. It might have delayed it during that 10 years. It might have lessened the outcome for it, but you're still going to go on to have a heart attack or a stroke. Unfortunately, that's the way that life works. All we can do with life is reduce our risks. Like going to cross a road, we can look, we can listen, we can check our surroundings, but once you've stepped onto that road, you never know what's going to happen. You can reduce your risk, but risks cannot always get to being to zero. What are the risks in taking a statin? And this is probably the thing that worries most people, as there has been a lot of media coverage about all the potential problems with statins in regards to muscle pain, liver problems, interactions, and it can be a big cause for concern when you're taking a tablet daily for the rest of your life, where it doesn't make you feel any different, and you really don't know whether it's actually going to prevent you actually having a heart attack or a stroke, or the date of your death. And that's an unknown that you will never know. So weighing those two up can be quite problematic. So I'm going to try and go through some of these and put some figures to it so that you can get an idea of balance and whether it's worth it for you. Now, you do find in all the trials for statins, especially sort of observational trials going forward, with people taking statins, that there is a very high rate of reporting of side effects. And this happens with a lot of medication where the known benefit can't be felt instantly, because you aren't feeling the benefits, and so you're not noticing those and recording those. But anything else that happens within your body, whether it was going to happen or not, you are going to notice, and you're going to worry whether it was due to the tablet. This is actually called the nocebo effect. So we have what's known as the placebo effect, where you can take a tablet and it can have an effect just because you think that you've been given something by the doctor that is going to work, and it helps your body be in a positive mindset, and you feel better. And the fact that sometimes you're going to get better, it was a self-limiting condition, and that's known as the placebo effect. And the nocebo effect is the reverse of that. You've taken something and you're worried about whether something that you're feeling in your body is due to that, and you put it down to the tablet, and that is known as the nocebo effect. And statins have one of the highest rates of nocebo effect. That's not to say that they are inert and don't cause problems, because they do, but we need to put that into context. So for the first one, like with the smiley faces that we've already been using, I'm going to use them again. So when it comes to muscle pain, this is one of the most commonly reported side effects for statins. And this is quite often because statins, especially in the early days, were only given once somebody had had a heart attack or a stroke and they'd suddenly gone through a major life change, or at the same time of being told that they are at high risk, they're also going to be making lifestyle changes. So either after a heart attack or stroke, you've had reduced mobility and that's affecting your joints and your muscles, or you've decided to try and increase your physical exercise because you know you're at higher risk of cardiovascular disease and stroke, and you're trying to improve your fitness. And again, that can lead to muscle pain. So in general, 26 in 100 people that are taking statins will get muscle pain. And the majority of them may put it down to it being the statin. So quite often what you'll be asked to do is maybe stop taking the statin, see if the muscle pain goes away. and then restart the statin and see whether it comes back again, to do that trial and error to actually double check whether it was definitely the statin or whether it was something else that was going on in your life. And what they found from the trials and comparing sort of the placebo arm to the actual arm is that although 26 in 100 people get muscle pain, only 2 of those were actually due to the statin. Now, this does come along with there is a very, very low risk of severe muscle damage, than myopathy or rhabdomyolysis. And this can occur with statins, but it is extremely rare. It is only 3 in 10,000 people that get this severe condition, although GPs will make sure that they tell you to report if you are getting severe muscle pain so that they can get on top of it straight away and stop the statin. But 9,997 people out of that 10,000 do not get this. So it's not something that you really need to worry about, although when we are treating millions of people across the country, it is something that GPs need to be looking for. And the next issue that people always worry about is liver problems with statins. Now, statins are metabolized by the liver, and therefore, before you start on a statin, your GP will want to check that your liver is in good condition and can cope with another tablet that needs to be metabolized by the liver. Then again, 3 months later, you will have your liver function test checked again to check that your liver is coping with yet another medication that needs to be metabolized by the liver. However, statins are extremely safe on the liver and they don't really cause many liver problems. And occasionally, maybe in the first couple of months, there may be a transient raise in some of the liver enzymes as your liver gets on top of a new thing to metabolize. But on the whole, it generally can cope for the majority of people. Obviously, if you are taking lots of other medicines that require metabolizing through the liver, your GP needs to take into account, and you can always discuss this with your pharmacist, whether there's any interactions. And obviously liver alcohol is metabolized by the liver, so if you are over consuming alcohol on a regular basis, this does put more strain on the liver, and this may impact how you can actually metabolize the statins as well. So moderate alcohol intake while you're taking a statin is recommended, as it is always. The next risk that got raised quite highly was that there seemed to be slightly more people getting diagnosed with type 2 diabetes in the first couple of years of starting a statin. And there possibly is some truth with this. They've done some very large studies over 4 to 5 years that shows that although 5 people of those 100 was going to be getting type 2 diabetes, there might have been one extra person that got that type 2 diabetes slightly earlier. Now, this does rely on what your underlying risk of type 2 diabetes is. The higher your risk, the higher the chance that it might hasten that along. However, diabetes itself is a risk factor for having a heart attack and stroke, for which you would then require to have treatment with a statin. And the treatment with the statin does not actually alter or worsen the actual type 2 diabetes that you've got. So if you've got type 2 diabetes and you start on a statin, you don't need to worry about it actually making your diabetes worse, but it really will help lower your risk of cardiovascular disease and stroke, which you are at higher risk of with having type 2 diabetes. Now, on to grapefruit juice. Now, this is specific to grapefruit juice and not actual grapefruit, the raw fruit, as it is very unlikely that you can eat enough of the actual raw fruit for it to cause a problem. However, in grapefruit juice, when it's concentrated, there is an enzyme in there that interacts with your liver metabolizing enzymes and may actually slow how your statin is metabolized and excreted out of your body. Therefore, you may need to avoid having large quantities of grapefruit juice, as you may get a slight increased risk of side effects from your statins. The other thing you've probably been told sometimes with your statins is to take it in an evening. Now, this isn't essential, but it does help the statin work better. And that's because it's overnight while you're fasting and asleep that your body processes cholesterol. And if your statin levels are higher overnight while your body is doing that, it will help the statin be more effective. But actually being able to remember to take your statin every day is the most important. So if that happens to be with your morning meds, and that's when you can remember to take it, then keep that in your routine. It's only if you can consistently remember to take it in an evening, maybe you have other evening medicines, that taking it in an evening would be of benefit. When it comes to NHS guidelines around statin therapy, they are comprehensive and complicated. So I will be sharing these links in the description box below if you wanted to go and look in depth for your own situation or your own knowledge. But I will try and give a quick summary over these. So, as you can see, the National Institute for Health and Care Excellence in England has produced guidelines for lipid modification, which includes statins and other therapies such as fibrates, omega-3 fatty acids, which I've also done a video about, and some of the newer agents that are on the market that can help reduce really high cholesterol, especially from familial hypercholesterolemia. So these guidelines, you can go through them all. There's lots of information about when you would use it for primary prevention in cardiovascular disease. So this is before you've had a heart attack or a stroke or anything that sort of shows up as definite, but you've got a lot of risk factors. Say that you've done the calculation of your Qrisk, and this is usually recommended when your Qrisk is getting above 10%. And then there's the lipid lowering treatments for secondary prevention. So once you have had a heart attack or a stroke, so that you know you are definitely at high risk of some other event happening again in the next few years, and trying to reduce that. Then there's information about optimizing people on the dose of statins. As I said previously, we used to put people on simvastatin, either 20 or 40 milligrams, but over the years we've come to realise that it is optimal to be getting people on either atorvastatin 40, and especially for those at the highest risk, atorvastatin 80 milligrams. We've also found that just starting people off at the higher doses actually reduces the risk of side effects, and actually increases the tolerability of statins by just getting straight in there with the dose. Because if you actually start on a lower dose and then keep increasing at each point of increasing, it increases the risk of the side effects, especially that nocebo effect that we talked about earlier. So these guidelines, you can print them out in PDF. It's 48 pages long. They've even done a 2-page summary, but when you come to look at the 2-page summary, as you can see, yes, they managed to get it down onto 2 pages, but it is extremely complicated, going either primary prevention, working out the Qrisk, whether it's greater than 10% over the next 2 years, whether you've got type 2 diabetes, type 1, but had it for an extended period of time, kidney disease, or as you are getting older, and then secondary prevention, needing that treatment straight away when you've had angina, acute coronary syndrome, a stroke or a TIA. And yeah, they get very complicated, but if you are at all concerned on whether you think that you fit into any of these risk factors, have a discussion with your healthcare professional, have them go through, discuss all the risks and the benefits that we've gone through for your own personal situation. And then, as I said, there's targets. So we've got these guidelines, and to ensure that GPs are offering these guidelines out to everybody, there are standards and indicators nationally that all GP practices are looked at to ensure that they are actually getting all their patients in, doing the QR risk assessments, getting them in after they've actually been admitted to hospital with a heart attack or stroke, and ensuring that they're on the best treatment afterwards. So there is the standards and indicators. They are all public so that you can see what they've got. For cardiovascular disease prevention, they want to be ensuring that everybody that's been identified needing prevention have got information about how to stop smoking, keep a moderate alcohol, healthy diet and exercise, all that information and that support, and that they should be offered a statin if their risk assessment score, so the Qrisk is above 10%, that they are offered treatment with a statin therapy or an alternative. And then obviously people who have had cardiovascular disease. So all of these GPs are looked at to check that they are checking all of their patients, and that's part of what we class as their QOF, the quality framework, so that we ensure that they are being paid for the job that they are doing. You may also find that other local areas may have additional indicators that they're looking at, especially areas of the country where it's been shown that there are inequalities, that there are people of higher risk due to deprivation in the area. They may have stricter targets to reach to really ensure that there's extra resources put in place to ensure that all the patients are given the ability to access the healthcare that they need. My final thoughts as a pharmacist on whether you should take a statin or not. So statins definitely have been a game changer in regards to public health in helping prevent serious cardiovascular disease and strokes, and reducing deaths, or at least putting deaths off by years, and improving quality of life for millions of people. And this can be done now that statins are extremely cheap, at less than £1 a pack per month. And it is definitely in the NHS's interest to give those targets to GPs to ensure that all patients are offered statins, especially those that have had cardiovascular disease or a stroke, and for those that have got a Qrisk score of above 10% and they are unable to reduce those factors with their lifestyle. Whether you as an individual should take a statin, that still does need to be a discussion with your healthcare professional, but I'm hoping that you can use the information in this video to look at your risk factors, see if you can modify any of your risk factors. And if you feel as though you're at a high enough risk where it's that 25-30% reduction in having a heart attack or stroke over the next 10 years is worth putting in the time and effort for taking a tablet a day, then I would definitely encourage you to think about it, and be rest assured that the side effects are not as problematic as they seem. That if you do get muscle pain that you might think is attributed to the statins, it may not be. It may be due to other factors that are affecting your health at your current time in life, and it's always worth stopping that statin, reintroducing either the same statin or a different statin, and trying again. Obviously, if you do have severe side effects to a statin, you may not be able to tolerate it, and then you would need to discuss with your health care professional other options for ensuring that you can try and keep yourself as healthy and protected against heart disease and stroke as possible. Thank you for watching, and if you have got this far, please comment with a heart if you are doing your best to improve your own heart health. If you found this video interesting, please like and subscribe, and that will really help the YouTube algorithm share this video, and it will also help highlight future videos to show in your feed. You may want to look at my previous videos on other subjects I've covered, such as omega-3 fatty acids, which can help lower cholesterol, vitamin A toxicity, and melatonin supplements. And please comment below with any questions that you have. If I haven't answered all of your questions on statins, please answer them below. And if you've got any ideas on future videos that you would like me to cover.